Okay, everybody, welcome to day 2 of Bristol Data Week. I'm Kate Robson-Brown. I'm director of the Jean Golding Institute, which is one of the university's university research institutes. And we are institutes which are set up to support multidisciplinary research in a number of topic areas, including data science and AI. So I'm really delighted to be able to hand over now to our speakers for this morning. We've got a group of people coming to talk to us today about big data during the COVID-19 pandemic. And I think we're starting off with Venetia Walker, who's going to introduce the topic and then hand over to some of her colleagues. So thanks very much, Venetia.
Thank you, Kate. So yes, as Kate introduced, the topic for today's session is big data during the COVID-19 pandemic. And the session today is in a couple of parts. So I'm just going to give you a brief introduction. We'll then have 3 focused presentations that introduce what trusted research environments are and then how we've used them to look at vaccination and infection in the COVID-19 pandemic. And then I've got some thank yous to say at the end. So let's start with our introduction. We are a relatively new team, about 2 years old, of researchers at multiple institutions, including the University of Bristol and University of Cambridge. Most of the people in this team have started with us in that 2 years, so we didn't actually meet because of the pandemic for a long time. But it's been really great working with everyone, and we've really enjoyed getting to know each other and working in these new environments that Rachel will introduce shortly. So our funding comes from the COVID-19 Longitudinal Health and Wellbeing, which is one of 6 national core studies set up by Sir Patrick Vallance as part of the UK Scientific Office response to the COVID-19 pandemic. And the COVID-19 Longitudinal Health and Wellbeing National Core Study has 6 research themes, which you can see on this slide. And it also contains a sub-study called Convalescence, which is focused on the study of long COVID. So the results you'll see today mainly relate to that sub-study, the convalescence study, and then also to vaccination. So I'll now hand over to Dr. Rachel Denholm to introduce trusted research environments.
Thank you. So just briefly, what is a trusted research environment, a TRE? So they're also known as data safe havens, and they are a secure computing environment to hold data. And so the data stays in one place and people come to the data to access it and do their research. They often follow the 5 safe principles. So only accredited researchers, safe people can access the data. To conduct work on safe projects, which have gone through a peer-reviewed process for ethical approval. They are in a safe setting, so the TRE, which is often requires 2 authentication processes or more to access it. It's safe data, so it's de-identified patient or person level data, and it's also safe outputs. So it goes through a review process to ensure there is no disclosure risk associated with that output. And just briefly, we have been using TREs to access electronic health records data, which are collected during any interactions with health services. So this is your general practice, your hospitals, mental health services, etc. And they are administrative data, so they are not collected for research. So they are messy and complex. And often information is recorded using is coded data, so it requires a lot of processing to derive useful variables for your analysis, so code lists essentially to identify clinical phenotypes, tests, demographic characteristics, etc. So we have been using 2 TREs which we're going to present work from. The first is a national TRE called the NHSD TRE, and this has been an environment where a national extract from general practices has been collated and stored and this is the data for pandemic planning and research. It's a general practice extraction service extract, and so it has been standardized across all GPs in the UK, in England, sorry. And this is a general sort of schematic diagram of the information that is available. So that primary care data is linked to lots of other data. So from NHS Digital, we have secondary care data, as well as vaccination and testing information. We have specific audit data with very detailed information on specific outcomes such as stroke and heart disease, etc. And then you also have registry data from places such as ONS. And in that environment, researchers access the data and they do their data curation and analysis using software that's available within that TRE. And with NHS Digital, it's Databricks and R. And there are other similar TREs that are at a national scale, such as the Sale Data Bank, which holds Welsh data. And there's also a Scottish one, which for these projects, there's federated analysis across these 3 TREs. And the second one we want to introduce to you today is Open Safely. Open Safely, they have a TRE in the same way in that the data is stored in one place and linked in that TRE, but the way that researchers access it is very different. So the way that it is done is that you create simulated data, which is on your local data, on your local computer, and you do this in an open way through various platforms created by Open Safely. So you create your study definition, curating your data for analysis using GitHub, and this is all freely available and accessible by other researchers not outside of your project. You generate code lists, so those clinical phenotypes we were discussing, how you turn coded data into usable variables using their open code lists website. And then you send your specific analysis and what we call jobs actions to the real data using the Open Safely jobs website. And so just to compare the 2 TREs, Open Safely is a data set of from registered patients at GPs at a specific software these GPs use, so TPP, so 40% of the English population. They also have it for EMIS as well, but the analysis we're going to present is using the TPP registered patients, and they also have linked data sources as well to that primary care record. The NHS Digital TRE is for England wide, so it contains 98% of all GPs in England, and again, as we discussed, it's linked data to secondary care and COVID-19 testing data, etc. And then we've also got the Sale Data Bank, the Welsh data, which again is the whole population. I realised that was a very whistle-stop tour of TREs and electronic health record data, but that is so we have more time to discuss the interesting bits, the analysis. So Jonathan's just going to come and present some of that work now.
Thanks, Rachel. So Elsie, Horne and I are going to present this work, as I'll say, well, but on behalf of a large team that's been working together for getting on for 18 months now. And so they are listed here, and they include colleagues from Bristol, from the Data Lab in Oxford, now the Bennett Institute, led by Ben Goldacre, and from the London School of Hygiene and Tropical Medicine. So, and as Venexia said, it's all work that was funded by the Longitudinal Health and Wellbeing National Core Study, which includes all the institutions listed at the bottom. And I should, of course, mention Miguel Hernan, who's been fundamentally important in designing these analyses and is based at the Harvard School for Public Health in Boston. So, as we all remember, we got the fantastic news at the end of December 2020 that the COVID-19 vaccines that had been evaluated in randomized trials seemed to be extremely effective. And so here's the paper that was published in the New England Journal of Medicine on the 31st of December 2020. establishing the safety and efficacy of the Pfizer, that's BNT1262b2 vaccine, messenger RNA vaccine. And here is the paper a few weeks later in the Lancet, establishing the safety and efficacy of the Oxford Astrazeneca ChAdOx1 COVID-19 vaccine. So the vaccines were rolled out incredibly quickly on the basis of these randomized trials done at astonishing speed during 2020. But at the bottom, you can see that the amount of data available on efficacy was incredibly limited. So in the Pfizer study, among 10 cases of severe COVID-19 with onset after the first dose, 9 were in placebo recipients and 1 in a vaccine recipient. And for AstraZeneca, it was all a bit messier. They were combining 3 trials, and they said from 21 days after first dose, there were 10 cases hospitalized for COVID-19, all in the control arm, 2 classified as severe COVID, including 1 death. That was it. So randomized trials underpin evidence about the safety and effectiveness of healthcare interventions. These were done incredibly quickly. They demonstrated that the vaccines worked, and on the basis of that, the vaccines were rolled out. But that was not enough information to answer all the questions that policymakers then needed to ask about how the vaccines worked. And so the example of COVID-19 vaccination is an extraordinary example where most of the information on which policy has been based doesn't come from randomized trials. It comes from observational studies using electronic health record data. Randomized trials provide the best estimates of effectiveness in the real world, but a host of questions couldn't be addressed in randomized trials. Far-reaching policy decisions have been made using observational data. Now, such studies are trying to make causal inferences. They're not trying to establish associations between vaccination and health outcomes. They're trying to ask, if we do one thing compared to doing another thing, what is the causal effect or the comparative effect of the 2 things? And in the dominant paradigm, causal inferences are based on comparisons of counterfactual outcomes, which under what we might call the Neyman-Rubin causal model. So the Polish mathematician Jerzy Neyman, in his PhD thesis in the 1920s, introduced the idea of potential outcomes, which were then ignored for 50 years until the biostatistician Donald Rubin wrote a very important paper saying, this is how we should think about causation, and we should try to make causal inferences from observation and data. So the important point about counterfactual outcomes is we're comparing what happens in one situation to a person with what happens to the same person in a different situation. So for example, we've got one person here, and we want to compare the outcome if they're treated, which we denote by the superscript x equals 1, with the outcome in the same person if they're untreated, which we denote by the superscript x equal to 0. And the problem, the fundamental problem of causal inference, is that in most situations, you don't get to observe both those outcomes. If the outcome is death, then you either observe whether somebody dies if treated, or you observe whether they die if untreated. You don't get to observe both. So causation is fundamentally different from associations. If there's no causal effect of exposure X on outcome Y, then the probability of the outcome if the person is exposed or treated is the same as the probability of the outcome if we don't treat that person. We're asking about the effect of doing treatment compared to not doing treatment. Whereas associations are about seeing. What's the probability of the outcome conditional on observing x equal to 1 compared with the probability of the outcome conditional on observing x equal to 0. Now, it's a cliche, an overused cliche, to say association isn't causation, correlation isn't causation. You hear that all the time, you hear it in the news, you read it all over the place in scientific papers. That's pretty useless on its own. What the theory that's been developed based on counterfactuals allows us to do is to go beyond the cliche that association is not causation to establishing the circumstances in which we can make causal inferences based on associations that we see in the world. So we can extend our paradigm from considering one person to considering counterfactual outcomes in groups of people. So we've got a group of people and we want to imagine the outcomes on average if everybody's treated, and we compare those with the outcomes on average if everybody's untreated. And the difference between those two expectations is the average causal effect of treatment compared to no treatment. And when we think in this way, we can see why randomized trials permit causal inferences. If I randomize, then the people who get treated are selected at random from everybody recruited to my trial. And the people who are not treated are selected at random from the people I recruited to my trial. So the average outcome in the treatment group in a randomized trial is equal to, other than through sampling variation, the average outcome had everyone been treated. And the same applies to the control group. So we can immediately see that we can make causal inferences in the real world if we randomly assign people to being treated or untreated. But we also want and need, as I've said, to make causal inferences in the absence of randomized trials. And here, drawing causal diagrams or directed acyclic graphs helps. So in a directed acyclic graph, the arrows or the edges indicate the flow of causation. So in this graph, C is a cause of X, and C is a cause of Y, and X is a cause of Y. They're acyclic because a fundamental principle of causal inference is that you can't go back to where you were before. Causes happen forward in time. So C causes X and X causes Y, then Y can't go back in time and cause C, and they're graphs. And the theory based on these directed acyclic graphs, or DAGs, is mathematically equivalent to that based on comparisons of counterfactuals. The approaches lead to the same non-parametric estimators. But the great thing about DAGs is that they allow us to conceptualize and explain problems and work out where we might see biases in our observational data analyses. And based on this theory, we can understand reasons that we see associations in the world. Two variables are associated if, firstly, they're cause and effect. If X is a cause of Y, for instance, in a randomized trial, then we will see an association between X and Y when we come to analyze our data. Secondly, we see associations in the world because of the presence of common causes, which epidemiologists refer to as confounding. So if C causes X and C causes Y, then C will induce an association between X and Y, even if there's no causal relationship between X and Y, or it will distort the association between X and Y compared with the causal effect. The thing that was less appreciated until this theory became more widely known in epidemiology is that there's a third reason that we see associations in the world, in our analyses, and that is when we condition on common effects. So if X causes a third factor S, and Y causes a third factor S, and we imagine a world in which X is not associated with Y, so in the whole of the population, there's no relationship between X and Y, then if we condition on S, we induce an association. That was a real issue in the analyses being conducted at the early stages of the pandemic, because many studies of risk factors were done in hospitalized patients. And if you understand this theory, you understand then that conditioning on being hospitalized with COVID-19 distorts relationships between influences on being hospitalized with COVID-19. And so studying hospitalized patients is a very bad way to study risk factors for COVID-19. And that phenomenon of bias induced by conditioning on common effects is known as selection bias or collider bias, because the two arrows collide at S. So here's an example that we published in during the pandemic, a fairly trivial looking example, but it illustrates the point. In the general population, extensive studies, which I've carefully read, demonstrate that physical attractiveness and acting talent are unrelated. But both physical attractiveness and acting talent lead people to be successful actors. People with acting talent are more likely to be successful actors, we would hope, and more attractive people are more likely to be successful actors, we have to recognize when we look at our TV screens. So among successful actors, the two characteristics are inversely associated, and that's illustrated in this scatter plot here, where the red dots are the successful actors both of these factors are influence being a successful actor, and you can see that among the red successful actors, they are inversely associated. So if somebody is both extremely attractive and a successful actor, they are less likely to be good at acting. The two factors are inversely related among the successful actors. So there are three broad reasons that we see associations in the world. Two variables are associated if they're cause and effect, if they share a common cause, or if they share a common effect, and we condition on it in the design or the analysis of our study. Now, that's all very abstract, but we really did want to make causal inferences about the effect of randomized trials. And we can often clarify the meaning of our analysis and the appropriate analysis strategy by specifying what we call the target trial, the hypothetical randomized trial whose results we're trying to emulate, with the idea that if we succeed in our analysis in emulating the target trial, the two studies, the randomized trial that we haven't got and the observational data analysis that we do have, will yield the same estimates. And it's really important to think like that because it helps separate the scientific issue, what's the research question, from the technical one, how to analyze my data to answer the research question. And it also helps to clarify limits to causal inference. For example, people want to know what's the effect of having 2 doses of a vaccine compared to being unvaccinated, but I can't really answer that as a causal question. All I can do in a causal, the causal contrast I have to make is between assigning people to a two-dose vaccine schedule, which takes place over time, and comparing those to people who are assigned not to receive vaccination. So that idea was articulated by, it's actually quite an old idea, but it was articulated a few years ago by Miguel Hernan and James Robbins in this paper in the American Journal of Epidemiology, where they said, look, you're analyzing big data sets, conceptualize your question by describing your target trial before you start doing your analysis. So how does that apply to studies of vaccination? Well, the rollout happened incredibly quickly and incredibly successfully. And the best way to think about the target randomized trial is to imagine the same thing happening over time. And that was done in this paper in the New England Journal of Medicine by Dagan and colleagues, where they very rapidly analyzed data from Israel in early 2021 and demonstrated these are the results. These are cumulative incidents of infection and hospitalization and severe COVID-19 and symptomatic COVID-19. And these authors were reassured that they were mimicking a randomized trial because they saw what should happen, which is in the first days after vaccination, no difference between the two groups, which is exactly what we expect from the biology of vaccination. Your antibody response takes a week or two to kick in. So how does this sequential specification work? On each day, a vaccinated individual is closely matched to an unvaccinated or control individual with covariates or matching factors that we measure all the way up to the day of vaccination. So, for example, in the UK, you were essentially not going to be vaccinated if you'd had COVID in the last if you tested positive for COVID in the last 2 weeks, you were sent home again. So that time varying factor can be accounted for in this sort of an analysis. Follow-up then has to be comparable between the two individuals, the control individual and the vaccinated individual. So it continues until the control individual gets vaccinated, at which time we censor follow-up for each individual. And we can do sensitivity analyses, varying that by, for example, continuing follow-up for another week. We allow control individuals to be included subsequently as a vaccinated individual in a new pair. And using this approach, we can directly, as I just showed you, compare the cumulative incidence in the two groups and adjust for additional covariates beyond those used in the matching. An important characteristic of these analyses based on very large data sets is that we become much less worried about sampling variation and much more worried about estimating the right thing. So we're wasting a lot of data here because there are matching failures and we're ending follow-up early in order to achieve comparability between our pairs of individuals. but we are mimicking a randomized trial by comparing similar individuals over the same time periods. So Will Hume from the Data Lab in Oxford has led the study that I'm about to show you, looking at the effectiveness of Pfizer vaccine, the booster vaccination with Pfizer vaccine in England. And we've used that sequential approach. So eligible adults were aged 18 and eligible for booster vaccination during 16th of September to 16th of December 21. They were matched with eligible unboosted controls on a whole bunch of important variables, including primary course, vaccine brand, importantly, date of second vaccine dose within 7 days, prior infection, risk and age groups used for prioritization by the Joint Committee on Vaccination and Immunization, and age. And then we additionally control for the whole bunch of variables that we can measure in the rich, trusted research environment that Rachel told you about, of 7.3 million adults who received booster vaccination with Pfizer vaccine. About 5 million were eligible, 4.3 million were matched with unboosted controls, and then 1.7 million people who were included as controls were also rematched when they got vaccinated. So we had nearly 7 million people included in the study. And these are the results, with the left-hand column of plots being overall, and then the middle plot being when your primary vaccine was with Pfizer, and the right plot being when your primary vaccine was with Astrazeneca. And you can see the incidence of all the outcomes, positive test, COVID hospitalization, COVID death, and non-COVID death was substantially lower in the boosted in red compared to the unboosted group in blue. And when we estimate vaccine efficacy in this study, we did what the vaccine people like us to do, which is to convert hazard ratios, which are what I understand, to vaccine efficacy, which is 1 minus the hazard ratio. So here, the booster vaccine effectiveness against a positive test was estimated to be about 50%, against hospitalization, about 80%. So the rate of hospitalization was 0.2 in the boosted people compared to that in the 0.2 times in the boosted people, that in the unboosted people. Effectiveness against death was 88%. Effectiveness against non-COVID death was 80%, we estimated. That could be biased because beyond what we can control for, people who are at lower risk of death are more likely to be vaccinated, but it could also be because of the benefits of vaccination beyond deaths that are classified as COVID-19. And when we stratify, for example, on primary course vaccine brand, we see modestly greater efficacy of the boosting against COVID-19 death if your primary course was with Pfizer. And we don't see substantial differences when we stratify according to whether you were clinically extremely vulnerable or younger compared to older, although encouragingly, the differences were in the direction that should encourage us because the efficacy appeared to be greater in those at greater risk, those 65 and over, and well, certainly for that, but modestly lower in those extremely clinically vulnerable, but the boosting was still highly effective. In recent work, we've been looking at the comparative effectiveness of Moderna compared to Pfizer vaccination. These results are still in development. They're more recent because Moderna booster vaccination was introduced more recently. It's the same approach where early on we couldn't match people because there was only Pfizer booster vaccination being used. So this graph shows that the matching became successful from November 21 onwards, but then and then mainly happened during December 21. And the results suggest that the boosting with Moderna is actually somewhat more effective than boosting with Pfizer vaccination. So to summarize my little bit, sequential specification of a target trial provides a robust framework for estimating vaccine effectiveness in observational data. We estimated that Pfizer boosting provides 50% protection against positive tests and 80% protection against hospitalization, and early results suggest boosting with Moderna slightly outperforms boosting with Pfizer. And I'll hand over to Elsie, who's going to talk about the work we've been doing on waning effectiveness.
Great, thanks, Jonathan. So yeah, I'm going to show you some results from the study looking at waning effectiveness of the Pfizer and Astrazeneca vaccines over 6 months since second dose. So I've got a diagram here just to illustrate our study design. So can you see my pointer on the big slide? I can't. Oh yes, you can. So what we've got here on the far left of this diagram is the date of someone's second vaccination dose. We then leave 2 weeks for the vaccine to have an effect and for them to reach their full vaccination status, and that's where we start the follow-up. Then you can see that the follow-up time is then split into 6 4-week comparison periods. So in terms of our analysis, we used Cox models to estimate the hazard ratios for 2 doses versus no doses, and we did this independently in each of these 4-week comparison periods. Once we've got those estimates, we could then use meta-regression to estimate the ratio of hazard ratios across these 6 4-week comparison periods. And so just to kind of reiterate on some things that Jonathan mentioned with this. So he described the target trial framework and presented 2 studies that use the target trial framework. But he also mentioned the fact that you can't really use that framework when you're looking at 2 doses versus no doses, because you can't at a single point randomize someone who's unvaccinated to then have 2 doses plus 2 weeks. So this study isn't kind of within that target trial framework that Jonathan described, because it's just not possible. And what we're really interested in this study is the waning effectiveness of 2 doses of vaccine. In addition, Jonathan described some things about some concepts in causal inference, but using these piecewise hazard ratios where we're estimating the hazard ratio independently in each of these 4-week comparison periods, these hazard ratios don't have a straightforward causal interpretation, and I can kind of explain this using the DAG below. So on this DAG, you can see there's Y1 and Y2, and these are both outcomes. So for example, this could be death from COVID-19, and Y1 would be death from COVID-19 in the first comparison period, and Y2 death from COVID-19 in the second comparison period. So in terms of this DAG, this is illustrating estimating the effect of vaccination on death from COVID-19 in the second comparison period, so Y2. However, it's kind of implicit that to be at risk of death from COVID-19 in the second comparison period, you must have survived the first comparison period. So in effect, we've conditioned on Y1. So we've said, you must have Y1 equals 0, so have not died in the first comparison period. And you might recognize this from Jonathan's slide on collider bias, because here we've got 2 variables with a common effect, frailty and vaccination. We've got these 2 arrows pointing towards Y1, and we're conditioning on Y1. And this introduces collider bias or selection bias. And so we end up with an association between vaccination and frailty. So we've not only got this path with the arrow from vaccination straight to Y2, but we also have a path via Y1 and frailty. And so this is just showing for when we've got 2 comparison periods, Y1 and Y2. But as you can imagine, if we're looking over like the 6 comparison periods and trying to construct a causal DAG to represent this study becomes really complicated and probably not helpful in terms of interpretation. So in terms of like why we use the analysis strategy that we did, there are a number of issues underpinning it. So firstly, as you all know, vaccination rollout in the UK was risk dependent, with those who were at greatest risk of severe COVID-19 being vaccinated first. And so the kind of like risk, people's risk of COVID-19 and the time at which they got vaccinated varies across the calendar year. In addition, the incidence of COVID-19 varied across the calendar year, and there were also different variants of COVID-19 across the calendar year. So for these reasons, in our Cox models, the baseline hazards were stratified by the vaccine eligibility group of the individual and also by the region in which they were vaccinated. All of our comparisons were also matched on calendar date to account for these varying incidents in the different variants of COVID-19. In addition, because obviously vaccination was not randomized to people could choose whether or not they want to get the vaccines. So our unvaccinated group is highly selected and probably different from the people who choose to get vaccinated. So for this reason, we controlled for a wide range of confounding factors that we could extract from the electronic health record data that Rachel described. Vaccination also continued throughout follow-up. So throughout our whole follow-up, people who are unvaccinated were still eligible to get their first dose of vaccine if they chose to do so. And the people who were in the group with 2 doses at points throughout follow-up may have become eligible to receive a 3rd dose. Individuals who did receive subsequent doses of vaccine were removed from the analysis, so that we're really just focusing in on that effect of 2 doses versus no doses. SARS-CoV-2 infection also induces protection against subsequent infections. So individuals with evidence of SARS-CoV-2 infection were removed from the analysis. So you can imagine this in terms of if the vaccines do work, you would expect there to be less SARS-CoV-2 infection in the vaccinated group compared to the unvaccinated group. So then there's more protection from having had previous SARS-CoV-2 in the unvaccinated group, and this could make the vaccines look less effective than they really are. And finally, the allocation to the Pfizer and Astrazeneca vaccines was risk dependent, but this was not consistent across the different age groups. So in the oldest age group, Pfizer was available first, and the people who are most at risk were available first. So the people who are most at risk were more likely to be vaccinated with Pfizer. However, when you go down to the younger age groups, because there was a very small risk of blood clots associated with the AstraZeneca vaccine, Pfizer was preferred for the younger people. So for at the younger end, being less vulnerable to severe COVID-19 meant you were more likely to receive Pfizer. So now moving on to the results from this study. I think that the title is masked here, but it says waning effectiveness of the Pfizer and AstraZeneca vaccines. There's a lot going on in this slide, so I'll just kind of break it down a little bit to describe what's going on. So in terms of the columns we've got here of the different plots, these are the subgroups that we looked at. So we've got people aged 65 plus years, people aged 18 to 64 years who were also clinically vulnerable, people aged 40 to 64 years who were not clinically vulnerable, and people aged 18 to 39 years who were not clinically vulnerable. Across the x-axis, right down at the bottom here, we've got the number of weeks since the 2nd dose of vaccination. So we can see we've got 3 to 6, 7 to 10, and so on till 23 to 26 weeks from 2nd vaccination. And just to give some context in terms of the calendar time, we've also got dates down here. And so, for example, for the 65 plus year group, they were being followed up from the 15th of March. That was the kind of earliest follow-up date in that group. And then the latest follow-up date in that group was the 30th of November. And as you can see, that varies across the different subgroups because of the risk-dependent vaccination rollout. We've then got, in terms of the different rows of the plots, some of them are masked out, but up at the top here, you can see there's COVID-19 hospitalization. And what we've got on the y-axis is, on the left-hand side, the hazard ratio. So as Jonathan said, this is maybe how statisticians prefer to quantify vaccine effectiveness. But then we've also got on the right-hand side, the corresponding estimated vaccine effectiveness, which is here calculated as 100 times 1 minus the hazard ratio. And these are adjusted hazard ratios here, so they've been adjusted for confounders. So now to actually look at the results, we've got pink for Pfizer, blue for AstraZeneca. We can see here that looking at the kind of first points on each of these, for most of them, we've got hazard ratios of around 0.05. Oh, and just to note as well that the scale of the y-axis here is the log scale. So we've got a line at hazard ratio equals 1, which is the null effect of equal rates of the outcome in the unvaccinated and vaccinated groups, and that corresponds to a vaccine effectiveness of 0. But yeah, so what we can see here is hazard ratios of roughly 0.05 corresponding to around 95% vaccine effectiveness in the 3 to 6 week period after second dose. And this is fairly consistent across the subgroups, although there's a bit of variation between the different brands. But what we can see here is that quite consistently across them, they're all waning to around hazard ratios of 0.2 corresponding to vaccine effectiveness of 80%. And what's interesting here is that the slope of the line, so these lines were estimated using meta-regression, as I said on the first slide. The slope of these lines all appear to be pretty consistent, both across the different vaccines and across the different subgroups. So now looking at COVID-19 death, we've got fewer points on the plots, so fewer estimates for this one and wider confidence intervals. This is because COVID-19 death is a much more rare outcome compared to hospitalization. And for example, in the 18 to 39-year-old group, there's just not enough deaths there to be estimating the hazard ratios there. But again, what we can see is the points are slightly shifted downwards, so slightly higher vaccine effectiveness against COVID-19 death. But we're seeing, again, really quite similar rates of waning for this outcome compared to hospitalization. So now looking at positive SARS-CoV-2 test. So this is a bit of a different outcome because in this case, we've got some kind of behavioral factors as well, because people, although people were meant to get a test if they had symptoms for COVID-19, ultimately that was kind of down to the individual to do that. So what we're seeing here is at the start, kind of roughly hazard ratios of roughly 0.2, and again, these are waning over time. But what's interesting here is that the waning is resulting in the hazard ratios going to 1 or above 1. And as I said before, this corresponds to equal rates in the vaccinated and unvaccinated, or if it's above 1, that's actually higher rates of positive SARS-CoV-2 tests in the vaccinated group compared to the unvaccinated group. So obviously, we're not at all suggesting that getting 2 doses of the COVID vaccine makes you more likely to get infected with SARS-CoV-2 compared to if you hadn't had those 2 doses. But most likely what we're seeing here is unmeasured confounding due to like behavioral differences that we just can't capture with electronic health record data. So for example, one of like the positive results of getting vaccinated is that people might feel more comfortable to go out and meet people and go to social gatherings and things, and all these things make them more susceptible to getting infected with COVID-19. And then also there's some evidence to show that people who are vaccinated are more likely to report positive tests. So they actually end up in the system, because if someone takes a lateral flow test and it's positive, if they don't report that, that doesn't end up in our data. So we don't know about that and can't model it. And then finally, we've got non-COVID-19 death. And similarly to in the boosting work that Jonathan presented, we are seeing protection against non-COVID-19 death. Slightly lower here than in the boosting work, and there is a slight waning of it as well. Again, this is probably due to either unmeasured confounding or also errors in terms of recording COVID deaths as non-COVID-19 deaths, because we just might not have the information to record it as a COVID-19 death. So in terms of these positive SARS-CoV-2 test results, we were quite interested to dig a little bit deeper into this. So we carried out some additional analyses. Instead of looking at just positive SARS-CoV-2 tests, we looked at any SARS-CoV-2 tests, so including those negative ones, so kind of looking at like just the rate of testing in the 2 groups. And the results for that, those are here. So we've got the 4 subgroups again here in the different plots. And the scale is slightly different, still in a log scale, but you can see that that grey line is at 1. and anything above 1 corresponds to higher rates of testing in the vaccinated group compared to the unvaccinated group. And that's what we're seeing consistently here, that in fact, it's quite substantial that we're having generally 2 times or greater the rate of testing in the vaccinated group compared to the unvaccinated group. And this analysis, as were the ones that I just showed you, these are all adjusted for the pre-vaccination testing behaviour. So looking before vaccinations were rolled out, we also counted the number of tests that people were taking in that period. So that must be unaffected by vaccination because it was before the vaccines were being rolled out. We've adjusted all the analyses for that. So we can see that even with adjusting for that, there's still these behavioural factors that we've just not really been able to capture with the electronic health record data. And the final results that I'll show is the comparative effectiveness of Pfizer versus Astrazeneca. So in this case, we're comparing Pfizer and Astrazeneca directly. So we don't have an unvaccinated group. We're just looking at 2 doses of Pfizer versus 2 doses of Astrazeneca across these comparison periods. We've not included, you'll see here, there's only 3 subgroups here. We've not included the 18 to 39-year-olds because just so few of them received AstraZeneca that we're not able to do comparative effectiveness there. So what you can see here is, again, we've got the similar scale with the hazard ratios on the log scale here. Hazard ratios below 1, so below the grey line, are favouring Pfizer over AstraZeneca. So we can see that across all of the outcomes, quite consistently, we're getting lower rates of these outcomes in people who receive Pfizer compared to AstraZeneca. But what's quite interesting is that the slope of the line is positive, so the hazard ratio estimates are getting closer to the null value over time. And so we're seeing probably slightly greater rates of waning in Pfizer compared to AstraZeneca. And this is actually consistent with some results from some immunology studies that have looked at different waning in terms of the immune response with Pfizer and AstraZeneca. What we're seeing here in the bottom row for non-COVID-19 death is really very little difference between the 2 vaccines here. So this kind of supports the hypothesis that we've got some unmeasured confounding here that's related to that highly selected group of people who've chosen not to get COVID-19 vaccines. So to summarize, the rate of waning that we found was strikingly similar across outcomes and across the risk-based subgroups that we looked at. But despite this waning, protection against COVID-19 hospitalization and COVID-19 death remained high 6 months after the second dose. So at the moment, we're looking at different ways to kind of extend this analysis. So we're looking at extending the follow-up beyond 6 months and looking specifically in that Omicron era, kind of from mid-December and through 2022. We're also examining implications of previous infection because at the moment it's been estimated that roughly 70% of the population have been infected with COVID at some point. And so that's something that's becoming really, really important to account for in an analysis, but it's also proving to be really, really challenging. So that's kind of a big task that we've got ahead of us. Thank you for listening. And I think I'm passing back to Venetia to finish it up.
Thank you, Elsie. So we are now going to switch gears a bit, and instead of talking about exposure to COVID-19 vaccine, we're going to look at exposure to COVID-19 infection. So these slides were prepared by Rochelle Knight, and they focus on associations of COVID-19 with subsequent disease outcomes. So for these analyses, we have defined 3 different cohorts at different times because we know that the COVID-19 infection has varied throughout the calendar year. So you can see in the top left here, we have our 2020 cohort. This represents a pre-vaccination period. So it runs from the 1st of January 2020, approximately the start of the COVID-19 pandemic, through to the 18th of June 2021, which is the date that everyone over the age of 18 in the UK was able to get a COVID-19 vaccination. In terms of the variants this covers, this is mainly wild type and then moving into the alpha variant. The second cohort is a vaccinated cohort. So these are people that have received both of their COVID-19 vaccines, regardless of whether it was Pfizer, Moderna, AstraZeneca. And this cohort, their follow-up starts 2 weeks post their second vaccination date, or the 1st of June 2021. And this means that everyone captured in this cohort is likely to have been exposed to the Delta variant of COVID. And the follow-up for that cohort ends on the 14th of December 2021. So that's the approximate date where Omicron became the dominant variant. The third cohort is the electively unvaccinated cohort. And this is similar to the vaccinated cohort. They're just the people that have chosen not to receive their vaccine. So they follow-up for them starts 12 weeks post-vaccination date. So we can be sure that they haven't got vaccinated. And then again, it's anchored to the Delta era of the variant. So they enter from the latest of 12 weeks post-vaccination, or the 1st of June 2021, and that runs again through to the 14th of December 2021, when Omicron became dominant. So for these analyses, exposure to COVID-19 could be identified in 4 separate data sources that we have access to in the trusted research environments that Rachel described. So we have access to SGSS, which is the lab testing data. So when you took a COVID-19 test, a PCR test, it was recorded in a specific data set. We can also identify COVID-19 infection from primary care. So this is when you see a GP and they record a confirmed diagnosis of COVID-19 on your healthcare record. We then have access to SUS, which is a hospital data set that has dates of when you entered hospital with a confirmed diagnosis of COVID-19. And then finally, we have access to the ONS death registry. So if you end up on the death register with SARS-CoV-2 infection listed as a primary or underlying cause of death, we can find you there. So for this sets of analyses, we're looking at a wide range of outcomes. We started looking at cardiovascular disease, and we've already been able to preprint results relating to the pre-vaccination 2020 cohort. And we're currently preparing a manuscript related to the 2 other cohorts, the vaccinated and the electively unvaccinated cohorts. And we've started to extend our outcomes to cover diabetes, mental health, neurodegenerative, gastrointestinal, autoimmune, and respiratory. So some of these are ongoing and some of them are at the planning stage. What's common between all of these analyses that I'm speaking about is the statistical methods that we'll use. So the analysis itself will be a Cox regression that accounts for calendar time, and this will allow us to estimate hazard ratios with time since COVID-19 diagnosis. One of the challenges we faced with the big data that we have access to is actually running these Cox regression models. So we have found that we're not able to run the whole model using all of the data that we have available to us. So we've taken a sampling approach to make the models feasible to run. So for this, we retain everyone who is a case, and we take a random sample of the non-cases. So, and for that, we've chosen arbitrarily 10 controls per case. We then use inverse probability weighting to recreate the sample by weighting the controls back up to what they would have been originally, and of course accounting for this with robust standard errors to account for the sampling. All of the models that we've run are stratified by region, and they're adjusted for an extensive range of confounders, which we define at baseline, and cover all of the socio-demographic and health factors that we can capture in the electronic health records. We've also been able to repeat our main analyses that look at the whole cohort in specific subgroups of interest. So, for example, we can look at COVID-19 severity by separating people who are hospitalised with their COVID-19 from those that are not hospitalised with COVID-19. We can also look at specific age groups, separate sex and ethnicity groups, and also consider people's prior history of the events that we're interested in. So moving on to some results, I just wanted to highlight the different samples that are in the cohorts that we've used. So the pre-vaccination 2020 cohort was analysed in the NHS digital TRE. As Rachel mentioned, this has the whole English population, and by working in a federated way with the other TREs, we can actually include data from Wales, from the SaIL data bank. We have about 11 months follow-up in the results that I'm going to show for the pre-vaccination cohort, and 1.4 million cases in the English population of COVID. And then for the vaccinated and the electively unvaccinated cohort, for these analyses, we've been working in open safely. So we have a smaller population size because it's just using data from that one primary care provider. Vaccinated people are much more than the electively unvaccinated people. So there's about 13.5 million vaccinated and 3.2 million electively unvaccinated. Follow-up for these analyses are restricted to the 6 months that the Delta variant was dominant, and the cases 1.9 million in the vaccinated and 320,000 in the electively unvaccinated. Okay, so let's look at some results, starting with acute myocardial infarction. So here we've got 3 graphs from left to right, starting with the pre-vaccination period, and then the vaccinated cohort and the electively unvaccinated cohort. In the pre-vaccination cohort on your left, you can see that the hazard ratios in the weeks since COVID-19 diagnosis immediately are very high, up between hazard ratio of 16 and 32. And these drop off with weeks since COVID-19 diagnosis, but they remain above 1, that dark grey line that represents no difference between before and after COVID-19 diagnosis. The overall pattern is quite similar in the vaccinated cohort. So we have very high initial hazard ratio that drops, but in this cohort, we see that that hazard ratio by about the 6-week point is close to baseline. The electively unvaccinated cohort is quite small, so we're not able to look in the detail that we were for the pre-vaccination and vaccination cohorts. So instead of having 6 or more time points, we're just up at looking at 2 time points. But here you can see, again, the rates start high and drop low, and they don't really reach the baseline level. And just along the bottom of this slide for reference, we've got the number of acute myocardial infarction events that happen post-COVID-19 exposure. So here, instead of acute myocardial infarction, we're looking at pulmonary embolism, which is a venous event that might be associated with COVID-19 exposure. And again, in the pre-vaccination cohort, we're seeing these very elevated hazard ratios initially that drop, but on the whole, these remain much higher than the acute myocardial infarction results that I just shared. The vaccinated cohort, again, very similar shape, and this time they don't get back down to that baseline of 1. So in the acute myocardial infarction, we were seeing that vaccination looked like it was returning that hazard ratios to 1. That doesn't look to be the case for pulmonary embolism. So this slide relates to arterial thrombosis events. So this is a combined outcome that includes acute myocardial infarction and other arterial events such as stroke. So this, the benefit of looking at this is we have a much higher number of events following post-COVID exposure, which you can see along the bottom of the slide. The shapes I won't describe again in detail because they reflect acute myocardial infarction, but generally the shape is the same: high, returning to low, and hitting baseline for vaccinated, but not for the pre-vaccination period. And then similarly, we can summarize for the venous events. So here we're taking pulmonary embolism with some of the other venous events, such as pulmonary venous thrombosis and other venous events. And again, the summarized results reflect the pattern with high initial results and slightly different shape to the arterial results. The reason I'm showing you this is it's because in these summary groups that we can start to dig down into the subgroups. So on this slide, we've got the arterial thrombosis events separated into hospitalized and non-hospitalized COVID-19. So this is representing the severity of COVID-19. So in dark red, those are the people that were hospitalized with their COVID-19. In the lighter pink color, those are the people that were non-hospitalized with their COVID-19. And you can see that across the week since COVID-19 diagnosis, the people that were hospitalized with their COVID-19 had higher hazard ratios. And so on the left is the arterial thrombosis events. On the right is actually the venous thrombosis events. So that was true both for arterial and venous events, that hospitalized people generally came off worse. So to conclude and to summarize where we're going with this next, we have found elevated risk of specific cardiovascular outcomes post COVID-19. And as I described, the general pattern is this reduces over time and attenuates in maximally adjusted models. It does remain elevated for specific diseases, and it tends to be the more venous outcomes that we've seen the elevation rather than the arterial ones. And there's a higher risk in hospitalized COVID compared to non-hospitalized COVID. In terms of the future work for this part of the project, we, as I mentioned at the start, are looking to extend to other outcomes such as diabetes and mental health. We've also been looking at more outcome agnostic ways of studying this, so performing a PHEWES approach to look at multiple diseases simultaneously, and that will inform a clustering analysis based on the outcomes that we find to have an elevated risk. We also want to look at replicating clusters that we identify in electronic health records in other settings. So for example, the UK longitudinal linkage collaboration brings together cohort data and electronic health records, and we'll be able to take our clusters from the electronic health records and look with the benefit of that cohort data brought in as well. So just to round out the session today, I've just got some closing remarks and thank yous to say. So first of all, as I hope you have appreciated from the presentations, this work is involved a lot of institutions, a lot of funding, a lot of data providers, which we have tried to summarize on this slide. So thank you to all of them. I would also like to thank again our amazing team that have worked very hard to bring the analyses and continue to work very hard on all of that ongoing work that I just described. And then thank you to the JGI for inviting us to give this workshop and for you for attending today. Thank you.